And my single role here is to introduce good friend and colleague Alex Eniu. Alex is a medical oncologist at the National Cancer Institute in Cluj, Romania. He's a past co-chair of the treatment guidelines panel here at the Breast Health Global Initiative, and he's going to talk about the systemic therapy administration in the absence of trained medical oncologists. Alex.
Thank you very much, Bob, and I will start by thanking Ben for inviting me again here. It's a pleasure to be with this group of people for the last, 8 years, and it's rewarding to see that indeed I believe we've made progress since the initial global summit held in Seattle. I think we've made real practical progress in our work, and Ben needs to be congratulated for that. Now, the task I was given today was to talk about systemic therapies administration in the absence of trained medical oncologists. To start the discussion, I would say that we all involved in cancer treatment, what are trying to do actually is to prevent the natural history of cancer to happen, and that is to progress from a localized disease which is curable towards metastatic disease which is incurable. And we do that using therapy, of course. You heard about surgery, you heard about radiation therapy. It's my task now to talk a little bit about systemic therapy. And to make the point clear, I think that both the previous speakers mentioned, and I think we are all in consensus to agree that systemic therapy for breast cancer is of paramount importance, and it is very important if we want to make some progress in treating our patients with breast cancer. Now, one piece of information that I think it's important to keep in mind while discussing systemic therapies in the absence of medical oncologists is that I think we have seen a revolution actually in the classification in general in oncology and specifically in breast cancer. And since the initial classification based on the place of the tumor, the site of the tumor, it was simply said breast cancer if there was a tumor in the breast. We know from our colleagues, the pathologists, that in fact breast cancer can be ductal invasive carcinoma, or there are several types, and we learned about differences in treating and assessing those patients. And while they advanced their knowledge with immunohistochemistry, they told us that in fact the tumor can be estrogen receptor positive or HER2 positive, and that again helped us understand how to better treat and to assess those patients. And in the last probably 10 years with the high throughput techniques, we understood that in fact we are not treating one disease, we are treating different at least 4 different kinds of breast cancer, and that we have names for that. That's triple negative, that luminal A, whatever that means. It shows us that in fact we are dealing with different entities with different prognosis and different approaches, and there are some trends that maybe in the future we will be able, by using this high throughput analysis techniques, to be able to predict response to treatment A or treatment B. Now, how does that relate to low resource countries? I think the point I want to make is that in fact breast cancer is a complicated disease, and medical oncology is in breast cancer, in oncology in general, it's quite complicated nowadays, and we have to think about this revolution of classification and to understand that in fact it's not enough to see the tumor, to know the anatomy, but rather to understand the biology, what's driving the course of the disease, in order to be able to make meaningful treatment for the patient. So with that background, we go back to limited resource countries. And what we can see in a report from WHO is that, in fact, if you look at the burden of disease in the US versus in sub-Saharan Africa, you see that the burden of disease in sub-Saharan Africa is much larger than what it is in the US. However, the number of health workers in the US that are working to treat 10% of global burden of resources of disease is this high, whereas in sub-Saharan Africa that see a much greater number of breast cancer patients or cancer in general, the number of healthcare workers is very low. And which leads to the fact that medical oncologists are scarce. They are very few, and in fact, as I've seen in most hospitals, caring for cancer patients, it's not always, you have to acquire skills that are outside your specialty in order to help your patient. And trying to discuss what to do, what's the role of the medical oncologist in low resource countries, I look back in our manuscript and see what actually the Breast Health Global Initiative is proposing as a systemic therapy for breast cancer at the basic level of resources. And when you look at this table, you see that for stage 2 breast cancer, essentially you need to have tamoxifen, you need to have oophorectomy, and in terms of chemotherapy, classical CMF, AC, EC, or FAG. This is what our work is proposing. And when you talk about locally advanced breast cancer, which represents actually the great majority of cases in limited resource countries, again, the means that you need are again the same: tamoxifen, oophorectomy, and preoperative chemotherapy with anthracyclines or CMF. So basically what I'm trying to see here, and in the metastatic setting, and that's also very interesting, we are offering only tamoxifen, ovarian ablation, and the we didn't select any of the agents for chemotherapy, although this is different than what I've seen in practice, and we may discuss that, but in fact, even in low resource countries, if you have access to certain agents, you will have to use them in the metastatic setting because the patients are there. So this is a little bit of discrepancy that I wanted to show. What about endocrine therapy? I do believe that endocrine therapy can be delivered in the absence of trained medical oncologists, and that is because this is it has a lot of effectiveness and the toxicity is very low. And I highlighted here what are the strengths, and actually we do say in the therapy checklist, in the strength of this therapy, that it can be easily administered by general practitioner or surgeon, and I think this is true. However, there are a number of weaknesses, especially in which concerns tamoxifen, because although being a simple drug to be given, it can have some potential important and life-threatening toxicities, such as thromboembolic disease or endometrial carcinoma. So the system has to be prepared to deal with that kind of toxicities, which are, although rare. Well, for chemotherapy, things are a little bit more complicated because you need a lot of resources to be able to give chemotherapy, and we've tried to list them here in our therapy checklist to, be helpful for the people using these guidelines in the way of improving their services, to see what they need to have in their hospital if they want to give chemotherapy, and also to what they should ask from the health authorities in order to be able to deliver chemotherapy in a safe way. And there are a number of really essential things that I think are required to be in any hospital that gives chemotherapy that are high